Hello everyone. In this lecture, still within the female reproductive system, we're going to be talking about the uterus and its components. Let's start with the uterine tubes, which are these hollow muscular tubes that will nourish the oocyte and transport it from the ovaries all the way to the uterus. Each uterine tube is divided into 5 or 4 regions. We have the fimbriae, which are these numerous finger-like projections that will drape over the ovary surface. Then we have the infundibulum, which is at the end closest to the ovary that forms this expanded tunnel. And the cells lining the inner surface of the infundibulum, they have cilia that beat toward the middle region of the uterine tube. Next, we have the ampulla, which is the region in the middle of the uterine tube. The smooth muscle layers in the wall of the ampulla, they will actually thicken as we approach the uterus. Then we have the isthmus, which is a short region that's connecting the ampulla to the adjacent uterine wall. And then the short uterine part, which is a continuation of the isthmus, which will open into the uterine cavity. And the oocyte will travel through the uterine tube before it reaches the uterus. The uterus will provide this physical protection, nutritional support, and also waste removal from the developing embryo and the fetus. I think it's important to bring up that when we refer to embryo, we mean weeks 1 through 8 of development. And when we talk about fetus, we mean week 9 all the way to delivery. And the contractions in the muscular uterine wall will help to expel the fetus at the time of birth. Now, because the uterus is this big structure that will get even bigger, and like I said, it will have to do all these functions with regards to the embryo and the fetus, it will have some ligaments that will be important to stabilize the uterus, especially during pregnancy. So the broad ligament is a large mesentery that's enclosing the ovaries, the uterine tubes, and the uterus. So it's all of this on this model, and it's also this part down here on this other model. The uterosacral ligament, it will extend, like the name says, from the lateral surface of the uterus to the anterior face of the sacrum, and this will prevent the body of the uterus from moving inferiorly and anteriorly. So it holds the uterus back. So if the uterus wants to move forward, the uterosacral ligament will hold it in place. And lastly, we have the round ligaments that will begin at the lateral margins of the uterus, just inferior to the basis of the uterine tube, as we can see it right over here. They will extend anteriorly and pass through the inguinal canal before ending in the external genitalia. So remember that we also had structures in the male that passed through the inguinal canal. Remember what they were called collectively? They were called the spermatic cord, where you had the ductus deferens, and you had arteries and veins for the testicles, you had nerves and lymphatics, all those would pass through the inguinal canal to go down to the testes. And here we have that the round ligaments are the ones that pass through the inguinal canal, and they will end in the external genitalia. Now, these round ligaments, they primarily restrict the posterior movement of the uterus. So if the uterus wants to move backwards posteriorly, then the round ligament are the ones that will hold it in place. Let's talk a little bit about the gross anatomy of the uterus. So the uterus has what we call the uterine body, which is the largest region of the uterus. The fundus is going to be the rounded portion of the body superior to the attachment of the uterine tubes. Remember, we also had a fundus, for example, in the gallbladder and in the stomach. So it's this dead end. So from here, nothing can go further in this direction. Now, the body will end at this constriction that's known as the isthmus of the uterus. So we have one in the uterine tube, and now we have another isthmus in the uterus, which is this narrowing part of the uterus. And the cervix of the uterus is going to be inferior portion extending from the isthmus to the vagina. Inside the body, we find this space that is called the uterine cavity, which, as we see on this model, it will expand during gestation to accommodate the fetus or the embryo growth. Now, around the cervical muscular wall, there is a narrower opening, which is called the cervical canal. And this cervical canal is better seen on this model that has the fetus inside of the uterus because the uterine cavity is expanding. However, the cervix stays closed and we can clearly see the cervical canal. It's a little bit harder to see on this other model where the uterine cavity will be continuous with the cervical canal. Now, in the opening of the cervical canal, which is more specifically called the external os, there will be this viscous mucus feeling that's actually there to prevent the passage of the bacteria from the vagina into the cervical canal. And as ovulation approaches, the mucus becomes more watery, more liquid, and if the mucus does not change in consistency and remains viscous, then sperm will have a difficult time entering the uterus, and this will actually reduce the odds for the successful fertilization. And for this reason, treatment of female infertility may include drugs that make the cervical mucus more watery. Now let's talk about the uterine wall, which will have an outer muscular myometrium and an inner glandular endometrium. The uterine glands open onto the endometrial surface, and these glands will extend deep into the lamina propria, as we can see right over here. They go almost all the way to the myometrium. And under the influence of estrogen, these uterine glands and blood vessels and endothelial cells, they will change with the various phases of the monthly uterine cycle. And this glandular and vascular tissues of the endometrium, they will support the physical demands of the growing fetus. Now, the myometrium is going to be the thickest portion of the uterine wall. It's going to be composed of 3 layers itself of smooth muscle, which will be important to provide much of the force that's needed to push the fetus out of the uterus into the vagina during delivery. Next, the endometrium, it can be subdivided into what we call an inner functional layer, which is the layer closest to the uterine cavity, and an outer basal layer, which is adjacent to the myometrium. The functional layer will contain most of the uterine glands, and it will contribute most of the endometrial thickness, as we can clearly see from this image. Now, the basal layer will attach the endometrium to the myometrium, and it contains the terminal branches of the tubular glands, as we can see right over here. Now, the structure of the basal layer remains relatively constant over time, but the structure of the functional layer is the one that undergoes these cyclical changes in response to the sexual hormone levels. And these alterations are the ones that will produce the characteristic histological features of the uterine cycle. And this makes sense. This is why it's called the functional layer, because it will be the one that will be responsible for the functional part of the uterine wall. Now, we do have another layer which is called the perimetrium, which is the outer serous layer of the uterus. And this serous layer, it will secrete this lubricating fluid that will help to reduce the friction. Now, the perimetrium is also part of the peritoneum that covers some of the organs of the pelvis. But the 2 main layers of the uterine wall will be the endometrium and the myometrium, being that the functional layer which is the one that takes the bigger part of the uterine cycle, is present in the endometrium. Now let's cover the uterine cycle, which can also be called the menstrual cycle, and it will average about 28 days in length, but it can definitely range between 21 and 35 days in normal individuals. The uterine cycle will be divided into 3 phases. We have the menstrual phase, the proliferative phase, and the secretory phase. The uterine cycle begins with the onset of the menstrual phase, which is an interval that's marked by the degeneration of the functional layer of the endometrium. So the arteries that are nourishing the functional layer of the endometrium, they begin to constrict, which weakens the arterial walls and reduces blood flow. And as a result of this, the secretory glands in the tissues of the functional layer, they begin to die. And the weakened arterial walls, they rupture, and blood pours into the connective tissue of the functional layer. Now the blood cells and the degenerating tissues, they break away from the endometrium and they enter the uterine cavity to be shed as they pass through the external os and into the vagina. Now the process of the endometrial sloughing, called menstruation or menses, it generally lasts about 1 to 7 days. And during this time, in fact, about 35 to 50 mLs of blood is lost. Now, some women may experience very painful menstruation, which can also be called dysmenorrhea, and may result either from uterine inflammation and contractions or from conditions involving adjacent pelvic structures. With regards to the hormones, menstruation occurs when progesterone and estrogen contractions decrease at the end of the ovarian cycle, and it will continue until the next group of follicles have developed to the point where estrogen levels start to rise again, as we can see from this image. Next, we have the proliferative phase. So during menstruation, the circulatory supply to the basal layer of the endometrium, including the basal portion of the uterine glands, they remain constant. Remember, I said that nothing happens to the basal layer. And as a result, the basal layer of the endometrium survives menstruation. And in the days following the completion of the menstruation, there are going to be circulating levels of estrogen that will rise. And under the influence of decirculating estrogen, the epithelial cells of the glands, they will multiply and spread across the endometrial surface. And this will restore the integrity of the uterine epithelium. So there will be continuous growth and vascularization restoration of the functional layer of the endometrium. And during the restoration, the endometrium is in what we call this proliferative phase. This restoration will occur while there's going to be the primary and secondary follicles are enlarging in the ovary, as we can see from the part of the image on top. And estrogen secreted by the developing ovarian follicles, they will stimulate and also sustain this proliferative phase. So by the time ovulation occurs, the functional layer is already several millimeters thick and it's highly vascularized. In addition, there are going to be mucus glands that will extend through the functional layer of the endometrium and are manufacturing mucus rich in glycogen. And this mucus is going to be essential for the survival of the fertilized ovum through its earliest developmental stages. Now, the reason why the functional layer is up and ready around the proliferative phase is because when ovulation occurs, and if the egg is going to be fertilized, the endometrium needs to make sure that it has enough nutrients to supply this fertilized egg. And therefore, that's why the uterine lining is already almost fully replenished by ovulation, but by the time the fertilized egg reaches the uterus, you can see that the uterine lining is at its peak. Next, we have the secretory phase. So during this secretory phase of the uterine cycle, the endometrial glands, they will enlarge and they will accelerate their rate of secretion because they want to be ready for when a fertilized egg arrives. So the endometrial arteries, they will elongate and spiral through the tissues of the functional layer. There's going to be a combined stimulatory effect of progesterone and estrogen from the corpus luteum that will cause this increased secretory activity. And this phase begins at the time of ovulation, and it will persist as long as the corpus luteum remains intact. So if there's a fertilization, the corpus luteum will remain intact. Now the endometrium secretory activities, they will peak about 12 days after ovulation, as we can see from this image. And over the next day or two, the glands, they become less active, and the uterine cycle ends as the corpus luteum stops producing stimulatory hormones. So a new cycle then begins with the onset of menstruation and the disintegration of the functional layer. Now the secretory phase usually lasts 14 days, and as a result, the date of ovulation can be determined after the fact by counting backwards 14 days from the first day of menstruation. Now, what will happen to these hormone levels if there is a fertilization of the egg? Therefore, if there is a pregnancy, so progesterone will be the one hormone that will be responsible for maintaining the pregnancy and preparing, for example, the breast for lactation. It will also be responsible for maintaining this thickened uterine lining during the menstrual cycle, as we can see from this image. A couple more terms that's important for you to know. So the first uterine cycle is termed the menarche, and it usually occurs at age 11 or 12. And the cycles continue until age about 45 to 55, when menopause, which is the last uterine cycle, occurs. And between these two events, the uterine cycles are interrupted only by unusual circumstances such as illness or stress or starvation or pregnancy. And irregular uterine cycles are characteristic of the first 2 years after menarche and the last 2 years before menopause. But if none of these events are occurring and your cycle is not consistent, then you should definitely go see your doctor. Not that it can be something serious, but you should get checked.